Hello. Good morning. we had uh, we had a wonderful the academic feast. So we'll start the last day today. Challenging CD presentation structural. I request Dr. Soumik Ghosh to present the closure of giant pulmonary AVM by minimally invasive procedure using catheter intervention.
Hello, respected teachers on the dais, and good morning everyone. My name is Dr. K. Arun Kumar. I am the Senior Resident, Department of Cardiology, Institute of Medical Science, BHU. I am presenting this case on behalf of my mentor, Dr. Soumik Ghosh, Assistant Professor. This is a case of closure of a giant pulmonary AV malformation by minimally invasive procedure using catheter intervention. This is the case history. This is a 16 years female presented with history of cyanosis since childhood period with fatigue since 5 years to presentation to our institute's OPD. It was average built. She was poorly nourished with presence of conjunctival suffusion and pan-digital clubbing. We can see that there is pan-digital clubbing is there, and on 12 lead electrocardiogram there is no non-specific some T-wave inversion in V1 to V3, and there is a lobulated density in the right hilum. And clinically there was normal pulse and blood pressure with no raised jugular venous pressure with no murmur. And this is the coronal section of a CT pulmonary angiography which reveals an abnormal fistulous communication between the right main pulmonary artery to right superior pulmonary vein. These are some CT images with the axial and coronal section which reveals that there is a large pulmonary artery and venous malformation is there. Then it was planned for a device closure. First of all, we have what we've done is we have taken right femoral axis. Venous axis was done with 7 French sheath and arterial axis was done with 5 French sheath. Now a pigtail was introduced through the venous line, and in left anterior oblique view, dye was given, 20 ml dye with 15 ml per second dye was given, which shows a large AV fistula. This shows a large AV fistula which communicating this right main pulmonary artery to right superior pulmonary vein. Then we negotiated this AV fistula through the J-tip thermo wire through the fistulous tract, and it was taken to the right pulmonary artery, then right superior pulmonary vein. Next, with multipurpose catheter, the thermo wire was proceeded over. Now the thermo wire was taken from right atrium to right ventricle, then main pulmonary artery, then right pulmonary artery, then through the pulmonary AV fistula and through the right superior pulmonary vein. Then we went to the left atrium, then left ventricle, then aorta, and it was kept in the right subclavian artery. Then snaring was done through the arterial sheath, so that to arterial segment of the wire to straighten the fistulous loop. Here you can see the snaring was done. Now we have the venous sheath was exchanged with a delivery sheath of 8 French. Now we have taken the device through that delivery sheath, and device was taken. You can see this is after snaring. And this one, how we have taken the device through the sheath, and device positioning was done. Now, first time there was a malposition of the distal disc, but again we repositioned that ASD occluder disc. We can see then after repositioning the disc, now after repositioning, now we confirm the position of the disc in anteroposterior view. Now you can see the disc was positioned at the fistula site. You can see the LA disc. This was the LA disc of the septal occluder, and this is the RA disc, and this is the waist. And then this is, we have done the check angiography again to confirm the adequate closure of the fistulous tract, and we can see the increase in the pulmonary vasculature as compared to the earlier one, which was very less, and pulmonary vasculature was there. And finally, we released the device, and selective pulmonary angiography was done. This was done in AP view. This is post-procedure selective angiography. And the post-procedure X-ray, where this is one of the radio-opaque substance that is showing at that is fit at the right hilum, and this is again the coronal section of the CT pulmonary angiography, which shows that there is a septal occluder at the one end is in the right main pulmonary artery, and the other end at the inside the fistula. Now here we come to the conclusion that the pulmonary artery venous malformations are the rare congenital abnormalities with cyanosis and without murmur. In our case, the arterial saturation of the patient that rose up to 95% from 82% on the table post-procedure, and early diagnosis and curative management of the underlying disorder is the key for the effective treatment. And the take-home message is transcatheter occlusion of the giant pulmonary AV fistula is a feasible option for the closure of the such lesions, and a detailed anatomical delineation and detailed radiological analysis like triple phase CT scan and 3D reconstruction that shows the right choice for the device and what procedure to be undertaken. Thank you all.
Excellent presentation. How did you do the sizing of the defect, and what was the size of the device?
Sir, the size of the defect was 22 mm, sir. And we have put the device 26 mm.
How did you do? How did you take a decision actually? Angiographically or CT?
Both, sir. Angiographically we have done, sir. At that time we have taken this measurement, the size of the defect 22.
What was the size?
This is 22 mm, sir.
What was the device size?
26 mm, sir.
How did you decide that the landing zone, the narrowest point, because it's a track quite long, and how do you decide where to land the device, and how do you make the decision? Was there any gradient? You should have a narrow neck so that the device waist sits there. And that is the point you would have measured in the CT. Okay. And so it's better that you showed a good, it's a 3D accretion of the it's a volumetric accretion of the CT, and if there is a good reconstructed image to show the waist, that's the most important thing when you try to size the device based on CT. And otherwise, it's quite difficult to get it on an echo. Okay. The waist where this thing goes. Why can't you, why an ASD device? Why not any other device?
Sir, actually, it is a large size fistula, sir.
Yeah, no other devices would be able to be accommodating this thing. So only ASD device, and obviously it will have a very narrow waist, and when you try to release it, you will have a deformation and you have to make multiple this thing. So what's the purpose of making an veno-arterial loop here?
So to strengthen this, sir, actually we want a loop because that is a fistula
So you
was very
showed
large.
the other wire in the in the subclavian,
No, then we snared it through the femoral we have taken, sir.
down the aortic
the
arch,
femoral,
and once you delivered the sheath, you've taken it. How did you clinically suspect this case to be an AV fistula?
Sir, actually it was a case presented with us with sinuses and clubbing, sir. Clinically there was no evidence we didn't get. Again, ECG was normal, sir. X-ray, some lobulated density. Echo was actually normal, sir. 2D echo was normal. So we suspected some extra cardiac thing was there.
No
sir.
murmur.
No murmur, sir.
Do you expect a murmur here?
There can be a short systolic murmur can be there, sir.
So it is so big, there's no turbulence, you may not have a murmur.
Yes, sir.
But what else echo you could have done to pick up this in echo?
Bubble contrast echo.
Bubble contrast echo, and what do you expect? What's the finding you get in the bubble contrast echo?
Sir, that feeling when we give that injection, sir, within 3 cardiac cycles, that
LA will get the bubbles.
Yes.
Nicely done.
Thank you, sir.
Not done here actually.
Sir?
Contrast echo is not done.
No, we don't. Thank you, sir.
Now CT is available, so any suspicion you can directly go for a thing.
Dr. Babu Yelumala is there. Dr. Muhammad Alamin. Dr. Muhammad Alamin. Pramod Sagar. Pramod Sagar. Percutaneous pulmonary valve implantation in a patient with bilateral branch pulmonary artery stenosis.
Yeah. Good morning, everyone. First of all, I want to thank NIC for the opportunity, and I want to thank Dr. Shivakumar, my mentor, who is the primary operator of this case. I will be showing a case of percutaneous pulmonary valve implantation in a patient with significant pulmonary regurgitation and bilateral branch PA stenosis. So our patient was a 25-year-old lady. It was a case of tetralogy. It was initially a case of tetralogy of Fallot. The initial surgery was LMBT at 3 months of age, followed by RBOT reconstruction and VST closure done at 6 years. Now she presented with progressive exercise intolerance, and echocardiogram showed dilated right atrium and ventricle with elevated RV systolic pressure, which was 88 with RV hypertrophy and RV dysfunction, as we can see here. The MRI also confirmed that the RV was significantly dilated with the RV-EDV, indexed RV-EDV of more than 150, which is an indication for pulmonary valve implantation with PR regurgitant fraction of almost 40%. So this is a CT. When we did the CT, we realized that the patient was having distal MPA stenosis. This is narrowed, and also we can see that both the origin of the RPA and LPA are narrowed. And there was a narrow segment at the annular level. The measurements were like 28 at the annulus. The mid portion, the mid MPA was dilated to 32, but the distal MPA was 18, and again the origins of RPA and LPA was half of the size of the hilar branch PAs. So an angiogram which was done and a cardiac catheterization also confirmed that there was a significant gradient across this MPA with almost 30 gradient between the branch PAs and the MPA, and additional more than 10 gradient across the proximal annular level. So with this, we need to address the stenosis involving the branch PA origins, the distal MPA stenosis, and we have to place a valve to prevent pulmonary regurgitation. So how to address this and what strategy to be followed? So now we actually we have been using a software called virtual reality for more than a year now, and whenever there is a very complex case, we do plan using virtual reality. This is a virtual reality reconstruction of the CT, like I'll be wearing VR glasses, and the controllers in the hand will be able to slice it and go through and see where exactly the branch PA origins are, the relation of coronaries. Here I have actually frozen it to show that there is a deep septum in the MPA, and here these two tissue are quite thin and they are not very rigid, whereas the tissue on this side is quite rigid. The again frozen image which will show the same, and here we can see that the LED was not close to the MP, like the place where we are going to stent, and the coronaries were safe. So if we virtually implant a stent and see what happens, it's a bifurcation stent. If we do a bifurcation stent strategy, we would actually place a stent from the proximal RVOT into one of the branch PAs, and then rewire to the other branch PA, place a stent, and achieve relief of this obstruction, and then plan a valve. But the problem with this is we will be using two large stents, plus when we go and deploy the valve here, the balloon, we will be using a balloon expandable valve because it is quite large, and when we go with the balloon expandable valve here, the distal part of the balloon will be either hindered by the stent that is protruding here, or occasionally or very rarely we can end up in having a puncture of the balloon which is catastrophic, and we will not be able to deploy the valve. So the other strategy we think was balloon angioplasty alone for the branch PAs. So here we can see that if we do a high pressure balloon dilatation, if we are able to break these small stents, we will be able to achieve a branch PA origin relief. But the distal MPA is probably will have stenosis, and we can land a stent from the proximal RVOT into the distal MPA precisely in such a way that the branch PAs are open, and once we achieve this and relieve the complete gradient, we can place the valve in the proximal RVOT. So we went ahead with the second strategy. We did the procedure under general anesthesia. The patient, we took bilateral venous access. We advanced two 12 French sheets up to the distal RVOT so that we will prevent the milking of the balloon proximally. We took two ZMED balloons, 22x5, and then we simultaneously inflated both the balloons so that we can see here the waste has been relieved. So once we did that, we assessed the pressure again, and the RPA and LPA pressures were 20, and there was no gradient, and there was a gradient across MPA which was roughly 20 millimeter. So the distal MPA need to be stented to relieve this obstruction. So to make sure that we deploy the stent precisely in the distal MPA, what we planned was we will upsize the right femoral venous sheet to 24 French, advance it to distal MPA, wire both RPA and LPA, and then mount the stent in such a way that we mount a stent on a balloon plus a JR catheter, so that we will have two orifices, and we can advance the JR catheter over the wire that is towards the RPA, and the balloon over the wire that is towards the MPA, and once we push it here, we will get a carina between these two wires, and the stent will stay here without being pushed into either RPA or LPA, and we can precisely deploy it. So as planned, we mounted a 42 mm Zephyr XXL which can go up to 32 mm, and on a 30x5 balloon plus a 5 French JR guide catheter. And we can see here the assembly has been advanced. We have been advancing it. There was some difficulty in the terminal portion, but we could clearly advance it into the MPA, and we can see the angiogram here which confirms that this is the location where we wanted the stent to be. So once we were there, we started inflating. Unfortunately, what happened was the balloon started milking into the LPA, and the stent was staying there, but the balloon started milking, and there was a issue with the stability. So we rapidly inflated as much as possible to make sure that the distal part of the stent is at least inflated and is held in the distal MPA that is narrowed. So once we did that, we did an angiogram, and that confirmed that the distal part of the stent is in the MPA and we are safe. But taking out this balloon now proximally and then inflating is a risk, because if we pull it backward, there is a very high risk that we embolize the stent into the RV. So to prevent this, what we did was the RPA wire was there which came to the rescue now. We took a 22x5 balloon first, we advanced and we inflated, then a 30x5 and we inflated, and we then secured the stent. You can see here the balloon in the LPA is still there, we have not removed it. Once we dilated this, we got a good stent apposition. We also opened we also crossed beyond the RPA, and we did a balloon dilatation with the Atlas balloon again, and we got a good opening of the stent, and we found that there was no gradient after this procedure. So once it was fine, the branch PAs were relieved, the MPA obstruction was relieved. So we took a 32 mm valve, which was not very difficult. We advanced it, we positioned in this proximal segment, inflated and deployed without rapid RV pacing. And when we did a pulmonary angiogram, we can see that there is no pulmonary regurgitation and there was no gradient. A coronary angiogram confirmed that there was no coronary compression. So the patient was discharged and extubated on the same day, discharged after 2 days. She is doing well after 6 months, and this is the echocardiogram which shows no PR and no gradient across the RVOT. So native RVOT is among the commonest substrates for PPVI. The distal MPA stenosis with branch PA stenosis make it even a more complex subset for the intervention. Bilateral PA stenosis can be addressed by stenting, but it can complicate further valve implantation. Sometimes balloon angioplasty can suffice in these cases. It can be decided by a virtual reality, which will help in a better understanding of the anatomy. Precise pre-stenting is very important, and the technique that we used in this case might be used to make sure that we are precisely deploying in these cases. And my valve is currently available up to 35 millimeter, and we can be safely deployed in all native RVOTs and with good results. Thank you.
Excellent presentation, actually. As usual, innovative from Dr. Sivakumar's unit. What was the echocardiographic gradient pre and post procedure? Did you do that actually?
And there was 60 gradient across the RVOT by echo, and there was no gradient post procedure.
What was the gradient?
Gradient was 60.
Pre-procedure.
Pre-procedure gradient was 60 across the distal MPA.
RV functions?
RV function was having moderate RV systolic dysfunction was there. And there was severe pulmonary regurgitation with PRRF of 40% on MRI, and RV was quite dilated, which was, I already mentioned that it was more than 150, which is a upper cutoff for selecting a case for a pulmonary valve implantation.
The post-procedural, the pressure grading actually?
There was no gradient. I had mentioned that there was no gradient across the valve at the end of the procedure. There was no gradient across the branch PS also.
What was the size of the stent?
The stent was the length of the stent was 42 millimeter. It's a Zephyr XXL, which can go up to 32 millimeter. We mounted on a 30 into 5 millimeter balloon, and we deployed it up to the nominal pressure. So we had gone up to 30 millimeter, and the 2 millimeter plus oversizing for the valve was taken, and we deployed it.
So you expected 44 millimeter. You expected a foreshortening of the stent, or?
This stent will not foreshorten a lot actually. This is a non-foreshorten. This is a Zephyr stent which has poly S and C links, which will actually widen out when we start inflating, and it is a non-foreshortening stent. We have done multiple bench testing and also clinical evaluation, which has found that the foreshortening is less than 2.5% in most cases.
You said the RV pressure was?
RV pressure was 80 at the beginning of the case.
The beginning of the procedure. And you did a rapid pacing while inflating the stent?
No, we didn't do rapid pacing because once we had actually deployed the stent will give a good landmark, and the stent will prevent it from migrating to and fro during the procedure. So if you have not done pre-stenting, we will plan to do rapid RV pacing. Otherwise, it's safe to do.
That's for the valve, it's okay.
Yeah.
While deploying the stent also, if a rapid pacing was done, would you expect that the balloon would have milked out?
That might, I'm not sure whether it would have not migrated, but the problem was the push that was required in the distal part to advance it to the MPA actually had pushed the balloon a bit more distal than the stent actually. Though we mounted precisely in such a way that it was in the center, when we were pushing, at the distal part, when there was some difficulty in pushing, the balloon actually migrated a bit more distal than the stent. That was the reason for that migration. Otherwise, rapid pacing, I don't know whether it would have really prevented that from happening or not.
No, definitely this valve didn't happen. There was no problem when you were deploying the valve. But we don't know whether because while we do a TAVI, we always do a rapid pacing, and we expect the mean arterial pressure to go below 30. So you told the pressure is 80 RV pressure before this thing. Maybe it could have helped if it is this thing. And what is the purpose? What is the purpose you another catheter to?
No, like we had taken 2 wires actually through the same sheath. So if you have to take we can't take balloon and stent over one of the wire, and the other wire will be outside the stent.
Yeah,
so we want the balloon, we want the stent, the other wire also within the stent actually. So if you mount a guide catheter on it, we advance one wire through the guide catheter and one wire through the balloon orifice, so that both the wires will be within the stent assembly, and we will be placing it precisely. Like otherwise, if we go and deploy only on either RPA or LPA, there is a possibility that as we see the balloon milk, there is a possibility that even the stent would have milked into one of the branch PAs, and we would have been across one of the branch PA, and we should open up the side of the branch PA, and all these things can happen. So to have a precise MPA stenting where there is no distal, where the distal MP is not very large, like we do this strategy and it usually works in most cases.
So technically it is to prevent the
To
stent
prevent the
migration
stent
while
migration
deploying.
into any of the branch PS. The stent didn't migrate. Stent actually
Yeah,
stayed
yeah,
because
stent
it
didn't
was there,
migrate,
but the
yes.
balloon, unfortunately, the balloon milked. But however, it could be fixed there. We were fortunate that it could be fixed there and we could bail out it.
Definitely this another catheter and the wire has helped in taking the second balloon. As you said, if you have taken the first balloon out, definitely because it could have, the stent would have,
If you had tried to pull the balloon adjust, we would have probably embolized the stent. So the other wire was there that
and
helped
that
in
helped out the purpose
securing
also.
it.
Yeah. So, yeah, excellent case. And so the sizing, everything done by CT, and you load that CT in that VR
Yeah.
software.
Yes, yes. Agree.
Nice, excellent case.
Thank you.
Thank you very much.
Is there any other presenters available or any
Soumya
chairpersons?
Kasturi. What is that name? Sitaram. Okay. Successful device closure of post-infarct ventricular septal defect.
Any other chairpersons have come? Yeah, go ahead. Kamam is, you're from?
I am from Khammam, sir, Telangana.
Telangana. Go ahead.
This is last successful device closure of post-infarct.
Good morning, sir. I am Dr. Sitaram from Telangana. So, our center is a district hospital which recently established cath lab there. There was no CT backup. So, we had a one case which was a very poor patient. He could not afford the price where the higher center. So, we have tried a case of post-MI ventricular septal rupture with a ASD device closures. So 60-year-old female patient, she was presented with, as previously 5 days back, she had a chest pain and shortness of breath. She was wandered here and there, and they finally landed into our hospital. That time the chest pain, ongoing chest pain was there, and shortness of breath class 2 was there, and associated PND episodes also was there. Hemodynamically, she was, systolic BP was 90, and the pulse rate was 105. And basal crepitations we could be able to hear, and loud murmur we could be able to hear. So initially we have stabilized with decongestive therapy and revascularized with LAD with 3.5 into 26. After revascularization of the LAD, patient was somewhat better, but pressures were not improving, and the shortness of breath failure symptom also not completely improved. So we thought to close the ventricular septal device. So this was the ECG of the patient. This is the evolved interval MI changes was there. And could you play the video? So this was the ventricular septal device, ventricular septal defect. On transthoracic echo only we could able to do at our center because TE is not available there, and the septum is the maximum size I could able to see is 0.91 centimeter was there, and there is a multiple tracks we could able to see. But no other separate opening or entry or exit is there. Only single entry and exit was there. Multiple small tracks are we could able to see. So then we have decided to fix with ASD, atrial septal device, as the patient's affordability was the issue. So with the Arogyasri backup, we could able to get the ASD device. And first, we have secured the two access. One is the right femoral artery and the right internal jugular vein. We have cannulated successfully, and then with a J-tip thermo wire, we could able to with the help of the Judkins right diagnostic catheter, we could able to cross the VSD, and we have snared at the left pulmonary artery, and we extrude from the right jugular vein. After that, we have passed the before sheath. We have seen the pressures at the pulmonary artery level and the wedge pressure, which is not very bad. So then we have decided to close the device. The with the help of the 8 French 45-degree curve, this Ampere Torque sheath, we could able to get with help of the company people. So this is somewhat better to deliver the device, especially in the VSDs, and it compared with the regular ASD delivery sheets. So with help of the 16 cardio O-fix septal occluder, we could able to fix the device. And after transthoracic echo, because the creatinine was bit higher side, so we didn't gave the contrast to see the pre or post leakage. Only with help of the transthoracic echo only, we have to satisfy the result. So then after procedure was nearly 30-40 minutes, we could able to see. But after procedure, patient was pressures was somewhat stabilized, 90-100 was there. And after 4-5 days, we could able to discharge the patient. So this is the video. You can see the with the help of the Judkins right catheter with the J-tip thermo wire. So in this video, whenever we are crossing the ventricular septal areas, better to cross the looping than going the straight. So in this video, you can able to see here loop, we are crossing the VSD. So that will be more like if any smaller VSDs also is there, that we can be more comfortable that we have crossed the bigger one. So at the level of the left pulmonary artery, we snared with the gooseneck snare. So after snaring, we have maintain a arteriovenous circuit. So with that, with help of this 8 French sheath, and the same time, whenever we are crossing the sheath across the septum, it won't be that easy to cross, because if you use the stiffer wires, there might be chances to damage more, and it compared with the thermo wires. If you use the sheath, stiffer wires, it will be easy to cross, but the damage will be the more. So that is the reason with the same J-tip thermo wire only, with help of the diagnostic, we just make the both kissing pattern like sheath and the diagnostic JR, Judkins diagnostic catheter. So you can see here, so both hugging up these two catheter, we slowly moved like a, with help of the another operator, we could able to see that both in the hugging pattern, we could be able to cross the VSD. So while crossing, it was a bit difficulty, but again, so once we have comfortable that we have crossed the VSD, then we have taken out the wire as well as the dilator, and we have taken the device, and we have opened the first the left ventricular side disc. Then once we are comfortable with the position, then we have started opening up the other ring. And after that, we have delivered the device, and with the help of the echo, you can see here, device was holding well, and there was a slight small tracks were there, but there was no significant shunt. So there was no major stunts. So after device, 4 5 days before device, it was nearly 4 days. So overall 9 days was hospital stay of the patient, and subsequently she was doing good. We have discharged, and now she is on follow up with a dual antiplatelet and statin. She is symptomatically good, sir. Thank you.
Very nice case and good outcome also. What is the success rate of doing a VSD closure as per literature, for post-MI VSR?
Procedural success is good, sir, nearly 80-85%, but
Overall
for
success.
post-procedure there will be a risk of the embolization or the contrast nephropathies. That is the other thing, because we have the challenging here is we don't have any supportive, not even IABP also, sir.
No, don't worry, you have done an excellent job actually. This kind of...
What was
it's a
coronaries actually? Coronary is on.
Coronaries LED, because of the time we didn't get, sir. Only LED was 99% was there, sir. Prior to the device,
Did
I
anything
fixed
for
it.
that?
Yeah, he's placed a
Yes,
stent.
the
Placed a
device I
stent.
have fixed the LED, sir.
LED. And that time you didn't hear any murmur or...
No, I have seen, sir. We have,
Oh, so
it
you
was,
were aware that the
I am aware
VSR
that-
was there
yes,
from the
yes.
beginning?
I have decided to revascularize first, and
And
then
because she's not affordable for anything, you went ahead. And how did you manage the finance? That's good anyway. Technically, it's a very challenging situation, not just the case. And you managed very well. And um, what is the size of the device?
16 mm, sir. The defect was some 9-10 mm, sir. So we have upgraded to 6 mm higher end.
Yeah, obviously you have to oversize more because of the fragile this thing, and the typical clinical scenario of elderly hypertensive female post-MI anterior late presentation. Everything is coming, but because when you have diagnosed before and there is a disease in the LAD, obviously we tend to send for surgery, but because of lack of availability and other things. But even surgery is not having an excellent outcome in these situations. And generally, if it is basal VSRE go femoral and jugular,
Yes, yes, sir.
and many times the delivery sheath is so shaped, it directly gets oriented towards the a defect in the mid to apical septum. And this kind of an AV loop, without that also sometimes we can
But this
manage.
sheath somewhat better compared with the ASD regular sharp 45-degree angulation sheath. It is
Okay.
a bit easier to cross the, because otherwise we need to shape it and we need to push it.
Yeah,
That time
little.
it may increase the size also, sir. So
What is the general difference between the acquired VSTs and congenital acquired VSTs and congenital VSTs?
challenge- challenge-
Nice closer.
so
Nice closer.
So hemodynamically, it is a freshly sudden onset, so the hemodynamics will be more deteriorated with the acquired VSD, sir. The technical or treatment aspect in a surgery won't be that healthier. So to either going for the device as well as the suturing also, it will be challenging. Suture at least devices after 2 weeks, usually we comfortably can we can deploy it, sir. But surgeons still they require the 4 to 6 weeks. They'll be more comfortable after 4 weeks. Because fibrosis, it will take nearly 4 to 5 weeks. So that is the main challenge as a natural course as well, sir.
Nice case,
Thank you, sir.
good outcome, and generally this kind of interventions will be, even in spite of all those efforts, the patient will succumb. And you are lucky that your effort has not gone waste, and keep up the good work. Thank you.
Thank you, sir.
Any other presenters are there? All other three are absent. That's all. Thank you. Thank you for participating.
check. Test. Hello. Hello. Check. Check. Test. Hello. Hello. Check. check. Hello, hello, hello. Check, test. Hello, check. Hello, hello. Check, test. Hello, hello. Check. Hello. Check. Check. Hello, 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 hello. Check, check. Hello.
क्या कर रहे हो? 8 नंबर से किया ना? बोलो
Check. Hello, hello.
कहाँ दे रहे हो? ग्रुप किया था ना आपने?
Check.
वाले 21-22 ग्रुप हटा दिया है क्या?
Check. Hello,
वापस आ रहा है ना इसमें?
hello,
म्यूजिक है?
hello. Check, check.
यहाँ तो चाहिए, रुको, ये मेन है ना?
Check, check, check. Check, check. Test. Hello. Check. Hello, hello. Check. Test. Check. Hello, hello. Check. One, check, check. Check. 0 dB पे. Check, check.
यहाँ से नहीं, रिसीवर बोल रहा हूँ। डब्बा डब्बे में आवाज़ ज़्यादा है शायद, अगर जीरो रहता है।
Check. Hello, 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 hello. Check. Test. Hello. Check. Hello.
அப்படி தான் போவோம் லாஸ்ட்டில். நம்ம என்ன ஏதோ ஆட்களை கூப்பிட்டு மூக்கரிச்சு என்ன காலேஜில் போய் உட்காந்து எல்லாத்தையும் வாங்க போஸ்ட் ராஜெலாம் கூப்பிடுவாங்க. லவ் பண்ணுவேன்னு லவ் பண்ணுவேன்னு பூபதி இந்த இதுக்கு வர்றீங்களா அது வாங்க வாங்க இது ஒன்றுமே நடக்க மாட்டேங்குது. You got the link, eh? Then you can start actually. Live case, Tower, University Clinical Hospital, Spain. Valladolid. Valladolid, okay. Valladolid, Spain.
Valladolid in Spain, for me is a great honor to be invited once again to one meeting in India. Unfortunately, I cannot be there in person this year, but I promise next time I will be there. Thank you again to the sponsors for counting on me for this presentation. And I'm going to talk today about the Vienna valve. I'm going to show a life-in-a-box case, but I will also share some tips and tricks that we've learned through the initial path with this technology. This is the design of this device. You can see that there are some radiopaque markers in the last iteration. It's a self-expandable device, supraannular and seatless. This is the case that I wanted to show you today. It's a good femoral access case. It's a 3-leaflet valve. And here we can see the initial orthography with in 3-cusp and 2-cusp view. We performed predilation. We did pacing over the wire. As you can see, there is no pacemaker lead in place. This allows to a very quick stop of the pacing. And this is the seatless system. You can see there is this inline 18 French at this moment. Probably in future generations it will be reduced. So once the tip is in, which is a very flexible tip, normally it's smooth all this way. Of course, if we don't want to go seatless, we can also use an introducer, but then it should be a larger one, so it's better to proceed with the seatless system, as usually in the self-expandable devices. Here you can see the flexibility of the delivery system along the aortic arc, and also how we can see the valve within the delivery system. You can see the catheter has a distal radiopaque marker, and the initial 10 millimeters, the valve will not start opening, so we don't need to do any pacing. We are doing the implantation here in a cusp overlap projection. You can see that we are pushing the wire all the way, the safari wire all the way to the apex of the left ventricle. And here the valve is going to start opening, so we might consider, if there is instability of the delivery system, some pacing at 100 or 120 beats per minute. You can see here the 2 radiopaque markers of the commissars. And along this process, it's important to keep this pressure of the wire towards the apex of the LV and some kind of pulling out of the delivery system, because the radial force of this valve is high, and therefore we need to maintain it in position. So it's the risk of upper embolization is low because of that radial force, but if we don't keep the tension out, then there might be some diving of the valve into the LVOT, which we don't want, of course. Yeah, you can see the slowly deployment. In the current generation, there is not a marker or a stopper where the valve is reseatable. Approximately 90% of the device can be deployed until now, more or less, and reseat. But after this point, we cannot reseat anymore. So we have to take the final decision. You can see the pressure is maintained along the procedure very nicely. And maybe the delivery system remembers you of something because it's similar to the trick valve one. So you can see that the deployment now is almost done. So we can go slowly, but keeping the tension out on the pushing of the wire. This is different from an Navitor or Evolut valves. We need to push the wire instead of pulling the wire. So we keep this tension towards the aorta. This is almost released. And as you know, in TAVI, this step, we must not rush because we risk to have a last minute movement of the valve where we cannot change anything. So take your time at this step. Don't rush. The valve is functioning. The pacing is stable. And you can see in the ECG that some bundle branch develop from the very beginning of the procedure before deploying the valve. We can see one of the hooks is released, but probably the other is not. We change the projection to make sure about it. We can see two of the hooks released, and one is still attached to the delivery system. So we just take our time to complete the full deployment of the device. And it's important to learn to identify this in this particular technology, and now it's fully released. So for the removal of the delivery system, we can rotate a little bit to make sure it's free. We pull the wire, take the delivery system out, and if we want to maintain the wire in place, we just push at this point the Safari wire. And once we are in the descending aorta, we can receive the delivery system. We just unlock and pull it back. Perfect. At this point, we can do the autography, which did not demonstrate any leakage, and we measure the gradients because this patient was part of the CMARC trial. We don't usually measure anymore the gradients invasively, but since the patient was in the trial, we did. And finally, we are mostly using one ProGlide, but in Vienna cases, we are still doing 2 ProGlides to be as standard as possible for the trial. And this is the final angiography with no leak, no thrombosis, no other complication of the vascular access. So as you can see, the procedure was very smoothly. This is another example of the simplicity of this procedure. You all know TAVI, so you understand these simple steps, but it's important that any new technology follows this standard current practice, because if it's more complex, then we won't do it. I just want to highlight in this case how we are pushing the wire and pulling the delivery system, because this is a particular feature of this system, different from others, and it's important to learn to recognize these steps. You can see again a very nice procedure. Sometimes it might be a little bit more difficult and we might need stiffer wires, especially if there is tortuosity of the iliofemoral axis or the aorta. Here you can see that we are starting with a very high implant. And again, pushing the wire. Some diving of the processes already occurred, but we could deploy successfully. We have used this valve in alternative scenarios as off-label indication, as in pure aortic regurgitation. This is one example of that. When we do self-expandable implantation in pure regurgitation, of course, we need to do more oversizing. This was a case for a 26 millimeter valve, and we selected the 29 millimeter valve. And I'm showing this not just to show how interesting this technology is because of the radial force, but also to show, how important it is to make sure we are completely released. We can do a gentle rotation of the delivery system. We can play with the wire, but never pull the delivery system. And this is the final result in pure regurgitation. And there was a little bit residual with the wire, but without the wire, no residual regurgitation and no complications. I have highlighted the radial force of this device, and maybe you are thinking that every company says they have a high radial force. But look at this case. This is a bicuspid case with a huge chunk of calcium. So normally we could select a balloon expandable device in this case, but the risk of annular rupture exists. You can see the fixed images here. So we decided to try with the Vienna valve. And this was the procedure itself. You will see it was not simple, but there were some features of this valve that are quite impressive in calcified anatomies. So crossing the valve, as usually in a very calcified bicuspid, was difficult. It was difficult to advance the catheter. It was difficult to position the wire. We needed to use a pigtail to make sure the stiff wire was completely supportive. We pre-dilated, but not very aggressively, I have to say. And then we performed the implantation of the 29 millimeter valve. You can see from the beginning it's underexpanded, but pacing was stable. We could remove the delivery system with no issues. And then we performed the post-dilation that you will see here with the same balloon we pre-dilated. So we decided to go with a larger balloon because in another projection you could see it was very underexpanded. And look here, the valve expands. We deflate the balloon, and after deflating the balloon, there is no recoil. So this radial force remains, and we didn't see any leakage or any annular complications in this patient. I know this is a very particular case, but I think this highlights that this is not an invention of an operator. This radial force exists in this technology. We have done some other bicuspid cases, maybe not so challenging as the one that I have shown with this eccentric anatomy, which is always a challenge for any kind of device, but in particular for self-expandable devices. You can see that there is more calcium in the angio than what we expected from the CT. This is the crossing, a little bit less challenging than in the previous case. The predilation, this time it was a little bit more aggressive. You can see that it took a while to expand the balloon. It didn't expand completely in the first inflation. This is something that we do sometimes, 2 inflations, the first one more gentle, the second one more aggressive. Again, we have somehow a small underexpansion, but stable patient, so we could remove the delivery system and complete the expansion of the valve with a post-dilation, as you can see here, with the same balloon that we used for the predilation. And again, when we deflate, here, the valve remains as we bring it to the size, to the expansion that we intended. So no recoil, and very nice result again. Some improvements from the first generation is now we can work with regular stiff wires like Safari. In the beginning, we only used Landerquist wire because it was a little bit more bulky, the delivery system. And the 18 French introducer sheath has reduced a lot the difficulties to access the femorals. And finally, some key learning points from my relatively limited experience yet with this valve. First thing is that there is not a stopper marking the last recitable portion, so be careful when you deploy, don't go too quick. When we are unsheathing, we should go slowly in the last portion because there is a 1-1 unsheathing, so if we rotate too quick, we are going to deploy too quick the valve, more than we expect. Also, don't expect to go all the way in the delivery system when you are rotating because the valve will be fully deployed more or less when this red segment is here. The valve is having a very good sealing and a high radial force, but there are some tips and tricks during the implant. We need to push the wire all the time, especially at the end, and we need to all the time. So all the forces need to align towards the aorta. Thank you very much. I hope you enjoyed the presentation.
Is there any questions?
It's a nice presentation from Spain. And how commonly you use the TE guidance in these procedures actually? Are you able to hear me?
Transesophageal echocardiograph.
You couldn't see the here actually. How commonly in Spain you use this TE guidance?
So, hi everyone, my name is Kaspros. I've done many cases of Vienna in Lithuania, so far around 35, and we did not use any TOE guidance for any of the Vienna cases. We only do few TOE guidance for the first ones, just to understand how the valve behaves, and it is not necessary to use it in every case. You can use only fluoroscopy, make sure you understand how the valve is working, and if you have coronary perfusion, and to detect any PVL.
When do you prefer to use filters actually?
So filters, like a sentinel filters for the stroke prevention, if I may have this question. So it depends on the calcification, of course, and what is most importantly from our experiences, not only with Vienna, but with the other TAVI valves, if we have a patient that he had already had a stroke before in his life, so this is the patient who is on the higher likelihood to having another stroke after TAVI procedure, and there are many risk factors that are involved in that. So I may only include sentinel devices for those patients who had a previous stroke, also really calcified aortic anatomy. It depends on the measurements. If you are using Agathon measurements, so around 2,000, that would be a number to justify a sentinel implantation before doing a TAVR procedure.
The transvalvular gradient during follow-up, if there is any change or...
Yeah, so basically that's a good question. So we have around 2-year follow-up now of our patients. See the same gradients as they were after the implantation. So there are mainly a mean pressure gradient or are single-digit gradients of around 8 millimeters of mercury on average in our 30 patients at 1 year follow-up ECMO scan, and some patients already underwent 2-year follow-up. We still see the same, and we do not see any changes in effective orifice area or any late complications or event of rehospitalization for those patients. And we also have a good quality of life improvement for those patients. NIHA class is reducing, also 6-minute walking test is increasing in distance. Therefore, we have a good quality for those patients as well.
Specific anatomy in which you avoid self-expandable valves and you prefer balloon expandable?
All right, so basically, when we talk about self-expandable versus balloon expandable, we need to understand that we should take balloon expandable valves in anatomies we don't see much of calcification at the aortic annulus, especially at the LVOT level, because we pose risk of annular rupture in these patients. Also, if you have a small annuli of the patients, then you would prefer having a self-expandable technology with a supraannular opening of the new valve leaflets that will help you to maintain a good effective orifice area after implantation and low gradients as well.
What are the dreaded complications you met during your procedures?
Right, so basically, we done the first procedures with the first generation device. So to talk about our main complications, even in all the TAVI procedures, even today, we did not find any vascular complications. So we were able to introduce the valve and take it out after the procedure without any complications. So there was no major bleeding event. In our particular cohort of patients, we only had one pericardial effusion because we were placing a pacing wire at the right ventricle, which was not a cause by the device itself, but the temporary pacing wire. So that was unfortunate, but the patient did not within 1 year. So we were able to save it by pericardial centesis. And we had one conduction disturbance, complete heart block with the very first implantation. And I think this is an early learning curve for many new devices. You don't know. So therefore, we implanted it quite deep in the LVOT, around 7 millimeters at the LVOT, which led to a complete heart block. After the went the pacemaker implantation the next day. And also we had one stroke event within 1 year for this particular cohort of patients with some mild residual neurological impairment even today. But the valve was really calcified, and we made two pre-dilatations for this patient, and therefore as well. And it's really important here to note that we did not find a need to do any kind of post-dilatation for this valve, as Amat already highlighted, the radial force of a highlight point, and I think sometimes you need to justify doing post-dilatations in other procedures, which, we all know that post-dilatation poses risk of stroke. Therefore, if there is no need for that, we have a good gradients, no PVL, with a good radial force after the implantation, in the post-dilatation is not needed.
What technique you use generally for when you have a low coronary heights?
So you need to look at you need to look at the CT scan first. So as per protocol that we included patients in the CE study, we needed to exclude patients which had low coronary heights, meaning lower than 12 millimeters. But then again, now after we do more cases, we also include patients that has coronary heights even of around 9 millimeters. Again, you need to measure the sinus of Valsalva wide. This is where you will understand if you're going to have a coronary perfusion after TAVI implantation. We did not find any need for chimney technique or any other technique to save the arteries from obstructing. And but I think the key important factor is just to make sure you look at the CT scan and you understand the anatomy of the coronary ostia, and not only the height but also the width of the sinuses, which helps for the coronary perfusion.
What is your experience on these techniques, or basilica techniques, to preserve the coronary ostium actually?
Yeah, so basilica technique is a technique when you need to do when you have a coronary risk of obstruction, and therefore this can be done. But we never did it on Vienna valve or any. We did not implant this Vienna valve in any failed bioprosthesis, and also so there's just no experience on that to comment, I guess. But I think in the future, if there is a need for that, it's not a problem.
If no more questions, we'll wind up this session. It's an excellent presentation, sir. Congratulations. Thank you very much.
Thank you.
Can we request Dr. Kaspras to just briefly comment on the radial strength of the valve so that this becomes a valve of choice in bicuspid anatomies?
Sure, Rob, it's a great question here. So we've done some cases on the bicuspid valve, as you also have seen in Amat cases as well. So I don't have anything to share here today, but basically it's really important to know that the radial force is really higher, even the Medtronic devices that you use in your practices. And you can also have no need for post-dilatation in a bicuspid anatomy, calcified anatomy. So it really depends also about the calcium distribution, of course. If you have calcified raphe, which sometimes needs to be expanded with the post-dilatation, but I would suggest first to do the implantation and analyze the gradients to understand whether post-dilatation is needed, because you will see the self-expandable nittilon to getting expanded more within some time after it gets into the bloodstream, and this is what we see, and this is where we did not need to have a post-dilatation in those patients as well.
Oh, that is great. So one final question, Dr. Kaspras. How often do you need to post-dilate this valve, post-deployment?
Yeah.
Maybe in your experience, how often did you do it?
So as I said, we've done around 35 cases now, and we only made, I remember correctly, we only made the post-dilatation for 2 patients. The one post dilatation was needed because we wanted to reduce some PVL, but we have really bad calcification chunk on the annulus level. So we want to just make sure we just reduce a bit of the PVL at that side. But, the PVL was left with mild, and the patient is doing well. But this was one reason. And the another reason, because we done it in a really calcified bicuspid anatomy, some constraint of the valve, even though we did not find a high gradients after implantation, but just to make sure the valve is not constrained in that anatomy, which was really calcified, we ended up having a post-dilatation, and the valve made a really circular shape after the expansion, and therefore the gradients were really fine, and even on the 1-year follow-up, the patient is doing fine.
Thank you. Thank you, Dr. Kaspras, Dr. Amit, and thanks, chairpersons, for being here. And it's a very early morning to you, Kaspras. Have a great day. Thank you so much for joining to this largest conference in the country. Thank you. Thanks, everyone.
Thank you. Have a nice conference. Thank you. Have a nice conference. Thank you. Have a nice conference. Bye.
Thank you.
So we'll start next session. Dr. Ravi, Professor Ravi is a facilitator. I request Dr. Ravindran to join. Dr. Ravindran, we have 2 cases actually. Dr. Bhupati is coming. I will start my Ganeshan's patients. I will start actually. It's a case presentation, not live in box. At the outset, I would like to thank the csiNIC. Dr. Ganeshan could not able to attend. I have not exactly live in box actually. I have a case, interesting case. I think you can discuss this case actually. This is basically a OCT guided decay crest it's a complex distal left main lesion. We all know the percutaneous intervention is an established treatment modality in unprotected left main lesion. The provisional stenting is currently favored in non-LM bifurcation. Many of the evidences suggest that, Bhupati, you can come up actually. I have one of simple case presentation, you can come and discuss actually. You come up. So provisional stenting is done because it is simple and easy to do. It often provides satisfactory results. There are several two-stents techniques that have been developed for LM bifurcation lesion involving the bone, main and side branches. As per the general protocol, T-stent is favored when side branch angle is 70 to 90. That prevents the protrusion of stent into the main branch. But when you have an angle which is unfavorable, less than 70, when you use this T-stenting, actually likely to have a protrusion of studs into the main, so it is better to have a crest or a collat. DK crest is one of the technique which has been studied extensively in various DK crest trial with strong evidences. The DK crest 5 trial reports has shown that It is novel important data is given demonstrating both incremental gain and some pain with decay crest over a provisional stenting for unprotected left main lesion. Recently, the coronary imaging, intravascular imaging, especially OCT, has contributed tremendously to optimization of bifurcation stenting techniques. When we had started the coronary intervention, the bifurcation was just a lesion. Now the bifurcation has become a club, bifurcation has become a branch, and it is a subspecialty. The science has evolved so much. If you look at the history of CRUS, the technique of CRUS itself is not the one. The technique which has been done somewhere around 2 decades back, originally among the two stents technique, even before the CRUS, clot was started in 1998. When the CRUS was started, classical CRUS original was started in 2003, that was the technique which was used was they just had a 5 mm protrusion of the stent into the main branch, and they did a stent CRUS generating a 3 layers and had a final kissing balloon inflation creating a 3-layer metal across the bifurcation, and that can produce easily, when there is larger the metal volume, the side branch stent, the failure, it can produce side branch occlusion. One of the important factor there was when they had only the one CRUS done, the recross, the side branch recross failure was around 20 to 25%. They could not able to pass the wire. Because of the recross failure, they were sending the patient for surgery. That is the main reason behind they started doing the modifications. They did a step CRUS in 2004, and decay CRUS original was started in 2005, where they did a 5 mm protrusion, they did a balloon CRUS, and generated again, first kiss was done to optimize the side branch, and they produced they did a stent CRUS and a final kissing balloon inflation, and again they generated a 3-layer CRUS actually. Then they modified into mini CRUS. Then decay CRUS contemporary, basically what the latest one which was done was they just 2 to 3 mm protrusion is suggested with a balloon CRUS, then followed by a kiss, then followed by a stent CRUS, then followed by a final kiss pot, and producing only 2 layers. That was the modification which has been extensively studied actually. They went on and again they modified into nano CRUS, decay nano CRUS. All this technique has been evolved just to improve the results. Now what we do is not exactly the decay CRUS now. My case is, what I'm going to show this case is there are a lot of steps involved. We have a double kiss, double CRUS, and double cross. They have a 3-pot and 2-time proximal side branch optimization and 4 pullbacks actually. So it involved not exactly the decay CRUS. This is the case history of a 59-year-old female, diabetic hypertensive. She is an engineering college professor, and she had presented with acute coronary syndrome, end-STEMI in another hospital. ECG showed an infralateral wall ischemia. Echo was normal LV function, so taken up for angiogram. Angiogram showed the left main bifurcation Medina 001, which is very difficult to take a decision. Decision making is it looks simple, and whether to compromise the left main, push stent, extend into the stent, and compromise the LM, have a provisional stenting strategy is very difficult. The syntax 22 technically looks like low risk technically, but it is challenging decision making there. A non-calcific severe osteal LCX lesion with, we could not able to see anything in LAD except for a mild haziness or a borderline lesion with normal right coronary artery. This was after wiring actually. I had 2 views to show this actually. This you can see this, there is a proximal LAD showing mild haziness, but exactly this was the lesion we had actually. This was the tight LCX lesion actually. So we wanted to profile it actually, but we wanted to look at the left main and LAD very well. Angiographically, you know, there is only a luminogram where we can see this two-dimensional thing, and intravascular imaging will give you a lot of insight, especially the pre-OCT will give a lot of insight into taking a decision actually. We all know it actually, angiographic medina, which is totally different from the OCT medina, which is more morphology based. So we did a OCT pullback from the LAD2 into the left main. And the distal vessel, we had a EL of 2.42. There was a landing zone, normal zone was there at 3.5. And when we went into the proximal LAD, it was fibrolipid plaque. And some of them, we had this a flap in the ostium, ruptured flap with a minimal thrombus actually. It was a high-risk lesion even in the proximal LAD. Even angiographically, it is a non-critical disease and which is extending into the distal left main actually. So what we could not able to see by angio, you could able to see in the OCT. OCT pullback of LCX was done. It was a long lesion. It was a long lesion with varied morphology. We had calcium, not much actually. We had a fibrocalcific, fibrolipidic lesion actually. The tightest one was at the LCX ostium, which mixed plaque, calcium with the flap, thrombus, classically ACS morphology, extending into the left main actually. So what we could not able to see angiographically, the imaging given an insert, making it is Medina 111. It is angle less than 70. Lesion is critical at the LCX. Lesion morphology is high risk at the LAD ostium, extending into the left main. So here we can't compromise the LAD here actually. So ideally we taken a choice of two stents technique. So we taken this DK crest. So 3 into 38 stent, it's a long lesion, was deployed in the LCX with 3 mm protrusion. Technically, we parked the balloon, the crest balloon distally, and when just inflating the stent, it was pulled into the proximal part of the stent. Make sure the balloon don't get trapped there actually. And we did after removing the LCX wire, we did the first crest. So you have to make sure while doing a crest, you have to remove this side branch wire. Then we did a recross, first recross. And the recross is a very important technique. You have to make sure it is ideally gone into the right place. You did a proximal recross. But how to confirm that actually, again, the OCT is useful. And we had a OCT pullback from the LAD. And again, when you redo it, we can again restudy the morphology, lesion length, and also we can select the landing also actually. This was a proximal cross. This confirms it actually. When the various techniques are used to look at the way, recross actually, the OCTs will show that it is definitely a cross across the proximal component of the cell. The first kiss was done. Then after the first kiss, the side branch wire was removed and we deployed 3.5 into 28 stent in the LM LAD with an optimal inflation, and that is the angio, check angio after the stent implantation with optimization at the left main using higher pressure 3.5 balloon. And after a pot, we did a second recross, and that is the OCT pullback after a second recross. You can see there is no medial dissection, well expanded, well opposed with the expansion of around 84%. We had a very good MSA. Left main, again, you can show this, the crust metal, the red one, you can see this is a minimal layer at the bifurcation point. Then we did a recross. You can look at this actually, the second recross was a middle recross. Then after confirming it, we did a final kissing balloon inflation and a final pot. And when you do this, we get this, our aim is to have a very luminal gain side branch, the L6 is being a very big branch. When you do this multiple step and proper analysis, we can have this result. You can look at again this, the metal layer across the LCX side branch. And you can look at this LM. LM is well expanded stent with very well opposed without any dissection. That's what result you want to achieve. Ultimately, you want to look at the LCX ostium, and this is the result we get it actually. You can look at this LCX axiom. You can have no metal across it when you do a proper assessment with proper optimization. Side branch PSOs, when you do a pot and properly recross, you will not have a metal across. And ultimately, this lady done very well actually. She's doing long-term follow-ups, she's doing extremely well. This was the final check. Angio. So now today the DK crest is not exactly only double kiss crest actually. You can look at so many steps involved, and the imaging, how much it is helpful, especially when you want to recross and you want to look at the course of the wire before optimizing or doing a kissing balloon inflation. So Angio Medina, we shown this based on severity. OCT Medina is based on lesion morphology. OCT gated DK crest is best. Now we have evidences, a good bifurcations technique. Pre-OCT MLD max algorithm, look at the morphology, length and diameter. Post-OCT, you look at the dissection, opposition and expansion. In between that, wire course, looking at a wire course is very important doing these procedures. Assessing a wire crossing by OCT is important, most important in DK crest. OCT guided DK crest is a perfect technique of choice. When you learn it actually in a complex LM bifurcation angle is less than 70. Outcome is based on perfection in executing and avoiding ostial metal bridge in side branch. So DK crest is a perfect illustration of more gain, no pain. Doing a DK crest in unprotected left main bifurcation is more challenging than provisional stenting but provide more benefit. And interventionalist will demonstrate an evidence-based mindset because we have evidences for this actually. You'll adopt DK crest as a standard of strategy when you are used to it actually. DK crest 5 has shown that both Excel and Noble trial would have been significantly more favorable for PCA arm if this technique is used in LM PCA arm. Thank you very much for opportunity. And any question or comments, discussion?
Very nice case, excellently done, excellently presented, and you have plugged in all the holes. I couldn't ask any questions also. Only one thing, did you do the OCT pullback from the circumflex at the end also, sir?
No, we did only a
LAD pullback.
But we could able to profile ostium, that was most important.
That's true,
actually.
yeah. That's because that is the Achilles heel in the bifurcation stenting of the left main. And angiographically at least, maybe there is a ectatic segment just after the ostium. Could you appreciate, because angiographically the proximal circumflex,
post-dilatation and optimization.
yeah, the proximal circumflex looks a little bit bigger than the osteoproximal segment, but definitely it could have been opposed. Maybe the distal, the proximal LCX is little more ectatic, because the area-wise it is very good.
Good morning. Yeah, Thank you, sir. Very nice case, very well demonstrated all the steps of the decay cross, which is useful for learning that now that more and more centers are doing left-hand cases. To which I can just add that it's excellent case result also. I can add that bed preparation is very important. If you see such a calcified lesion in left main, if somebody who is doing less number of cases, if the bed, I'll say, repeat that, the bed preparation is very important. Because unless you have done a good bed preparation by doing a pre-dilatation with NC on both sides, and once you are committed to a decay cross with a stent protruding into the L6, and if you cannot enter rewire, sometimes it can happen to anybody, then it becomes very difficult because once a committed stent is there. So that is one aspect. Second thing is this lesion, we can have other choices of bifurcation also. One of them is choosing a single stent towards from left one to L6. Another is going for a T stent also, having a less metal burden, because at the last, at least towards I saw that the angle was equal, I mean 50-50 for both the decay cross as well as for the T stent. Their metal burden will be less. Third is a simple mini cross for people who are not doing enough number of decay cross and they don't have devices like imaging. So I'd like your comments on these aspects.
Yeah, obviously, but we had, at that point of time, we had a good evidences favoring the decay cross actually. The imaging was very useful in assessing actually. You could able to profile the morphology prior itself and take the strategy of preparing the bed actually. You could able to prepare it. Initially, we have done with scoring. The ostium dilatation was done with, we have shown this, a lot of dissections were there actually. Then followed with, we did a very good proximal, the same balloon was used to do a proximal stent optimization. And you taken, I think, for the other technique or T technique actually, this angle was for D technique actually. But you would have had some amount of protrusion if you needed to not to have a geographical miss or ostial the miss. The LED is a very important branch. We have taken this crest technique as a choice.
Thank you very much, sir.
Thank you. Dr. Nagendra Bhubadi.
We will call upon Dr. Nagendra Bhubadi for case in live box.
थैंक यू माँ रुकेगा क्या मैं बॉक्स लेकर आ जाता हूँ ऐसे पकड़ना है क्या मैं बॉक्स लेकर चलो मैं पकड़ लेता हूँ कोई बात नहीं मैं बॉक्स लेकर आता हूँ चलो mine is a case in box so I will be playing it ऑडियो नहीं आ रहा मिस आ गया उधर वीडियो नहीं आ रहा अच्छा ठीक है Miss Maria, our cath lab nurse, Miss Kavita, nurse, Jyotish, our echo technician, our chief cath technician Karthi, and Surya, and all the team who have supported this case along with our management. So let us go with the particular patient. Dr. Sada, would you like to elaborate?
Yeah. Hi everybody. This is a 65-year-old man presented with inferior ulema in some other hospital. He underwent a primary PC for proximal RCA lesion. He had a zotrolimus eluting drug-eluting stent 3 into 28 millimeter. Initially he had a primary PC. Subsequently his angiogram also had a LAD and L6 lesions also. He underwent a staged PTCA for L6 in around 2 into 30 millimeter, 2 into 28 millimeter same zotrolimus. Also to check for all the echocardiogram which showed an inferior wall hypokinesia, and he was taken up for the case now.
So basically we have a patient who had a primary PCA to RCA for inferior MI in 4th of this year, that is April 4th of this year, and who had a staged PCA to circumflex. Both have been zotrolimus eluting stent, 2.75 30 on the right and 2.5 26 on the circumflex. In spite of having a very critical osteoproximal densely calcified vessel, operator did not want to do the PCA at that point of time. He wanted to do it as second stage setting. This time we proceeded with class 3 symptoms.
So let me go through the angiograph now. We have got a groin axis, right groin.
We went ahead with groin axis. That's a long video, so we have edited it to make it fit into the time. Groin axis and temporary pacemaker was not inserted, only a venous line was there. We went ahead with check angio of the right first, followed by check angio of the left. To our surprise,
Front sheath, long teeth have been placed. Ultrasound guided access was done. We would like to also thank Professor S. Ramesh, head of our department, who was also in this particular procedure. He has gone for a different meeting now. So this is the angiography done in this particular patient using JR4 guide catheter. Before the dye goes in, you can appreciate some amount of hyper intense structure seen at the ostium. Possibly we feel that the stents would have been deformed at the ostium, and there is ISR at the level of proximal stent, which is 60 to 70%. You can also appreciate a 90% to 95% is in the ostial PDA, which was not contemplated. At this point of time, next one. Next, now the left diagnostic shot says that patent circumflexion.
So basically we have when the diagnostic shot showed a hyperintense structure seen in the ostium, possibly the guide-induced stent deformation has already happened in the particular patient, which was not picked up at that point of time. And now he has got an ISR of 60-70% on the osteoproximal circumflex. He was having a persistent LA deletion. We aborted the PCI. We went back. One of the operators went back to the patient, talked to the relatives outside, and then they got convinced that they don't want to go for cabbage and proceed to PCI. Luckily, his circumflex stent is patent.
We went back to the patient, discussed with the patient regarding what exactly needs to be done. Would you like to go for a cabbage? However, the patient was categorically, family and patient categorically declined cabbage and billing for PCI. Now the strategy is to wire the RCA and treat the distal RCA also.
So whenever we have a ostial stent crowding, whether outside the ostia or just in the proximal segment, we will be having significant, we usually have difficulty in wiring in the central lumen. We also had in the same patient, so we took one wire, workhorse run through extra floppy wire. Definitely it didn't go into the central lumen. With that support, we will get our second wire with a looped portion inside the RCA, through which first IVUS was done.
Wiring the first wire went in abluminally, we could not get it, and somehow we got the second wire and got it, and then we dilated the lesion with the we did an IVUS actually. The IVUS, now let's go to the IVUS.
So we actually did IVUS. The IVUS actually showed a crowd. You can appreciate the IVUS structure here. It's a very big vessel, crowded stent at this portion alone, highly malopposed. It's a very small stent for this vessel. Crowded stents are seen in the 12 o'clock position says that's a deformed stent, malopposed stent, undersized stent, and under-expanded stent. Everything is seen in this particular picture. After that, we took a 3O, we measured the size of the distal vessel, which was actually 3O. It's actually a completely diseased vessel. One stent is up to here, and after that, it's only calcium. So we went ahead and dilated with the 3O OPN. The vessel was sized up to this point. It was 3.1 lumen to lumen. We took a 3O OPN and then dilated the
distal diameter was 3O. We took a 3O OPN, dilated the entire segment. We initially thought of doing DES. However, since the stent is deformed in the proximal segment, we took a larger stent this time. After dilating with the 3O balloon, we took a 416
Our original plan was to put a DCB. However, after confirming the stent deformation in angio and in the IVUS, we thought we have to put a new stent there to preserve the ostium. And the underexpanded portion in the underexpanded stent in the particular distal portion of the RCA, prior RCA stent was dilated with the 3O OPN up to 44 ATMs.
Stent was used, and the size of the RCA in the proximal most segment was actually 4. So we took a 4O megatron stent and deployed the stent at nominal pressure, and then post-dilated the same stent balloon. Ostial flaring was done to high pressure up to 16-18, and then we used the different 3.5 NC balloon all the way into the distal and mid segment of the distal portion of the first deployed stent and dilated to high atmospheric pressures. Final IVUS was done, which revealed a good luminal area in the proximal, and So you can appreciate already two studs of the RCA is protruding into the. This is the original IVS actually, the final IVS didn't come. So after that we went ahead with densely calcium. We were actually tired with that itself. So we thought of doing a staged LED left main PC. However, let me convince ourselves, let's do it. This is going to be a fourth procedure for the patient otherwise. So we convinced ourselves and took a EBU, not EBU, so the soft guide, XP guide, 3.5. LED lesion. The ostial diagonal has got some 40 to 50% disease, the major diagonal. D1 has got tight disease. The plan is to do a rotablation. So we used a rotor dry wire, entered into the distal LED and then do a burring with the 1.5 burr, 160. With the 6th minute, we were able to create the burring. We were able to open it. After that, we didn't go with IVS. We actually thought, let's do OPN. Yeah, after rotablating with 1.5 burr, we took a regular NC 3.5 balloon and then dilated the kind of proximal mid LED segment with a 3.5 well all the way up to 20. However, there was persisting waste. The same balloon what we used to RCA. However, the OPN balloon could not cross. Hence, we took a Wolverine balloon. We took a 3.5 balloon to dilate it. However, there was some waste in the lesion of the exactly above the major diagonal. So we took a 3O Wolverine, went up to 22 atmospheric pressures, and the same balloon was used to dilate the proximal LED also, along with the Carina. And we did IVS. Now let's look at the IVS. This is the IVS pullback of the LED after rotablation, after dilating with a 3.5 balloon, and after dilating with a 3O Wolverine balloon. LED, this is a mid-segment mid-distal LED, it's an intramyocardial course. At certain point, the LED becomes quite significantly bigger in size. This is a small LED. Yeah. Now the LED becomes a decent size. We measured the size at the particular portion. We'll go to the bookmark now. The LED comes around clock burn of 33% with a size of 3.5. So we measured the length of the left main to LED. We have created a good amount of luminal drain. There is no need for us to prepare the bed more. The left main is something around 4.5. So we took a 3.5 into 34 zotorubum saluting stent inside this particular patient, and then we deployed nominally. We deployed it. We kept one stent outside the left main. However, after dilatation, we use the reverse spotting technique, that is starting from the proximal rather than distal. Instead of doing reverse spotting setting, there was some stent elongation that happened into the aorta, so that now the one stent become two stent protrusion into the aorta. So we took another 3.5 balloon to completely dilate the LED. After taking a 3.5 balloon, there was still waste was seen. Hence, we took the same 3O OPN balloon. This time it went quite easily and dilated up to 42 ATMs. After that, we could appreciate some amount of opening of the stent studs. Following which, we did IVS. Now look at the second IVS. This is the second last IVS for the LED. We were okay with the mid LED minimal stent area. There was no distal edge dissection. Stents were very well opposed. However, the stent is elliptically dilated as expected because of the calcium. You can appreciate the calcium. Though it is elliptically expanded, the luminal area there is something around 7. We were happy with the results there. But however, as we go near the Carina, ostial LED, there was significant under expansion, show that portion. The distal left main had a luminal area of only 8.9. This is just at the Carina. So we thought we need to dilate it more. We went with the 14 atmospheric pressure up to using a 4.5 balloon. This time we used the same 4.5 balloon, went up to 20 atmospheric pressure inside the Carina, and just 12 atmospheric pressure just protruding into the ostial LED. After that, we did IVS again. Show us final result. Now the same portion which was 8.9 become reasonably bigger lumen. We got a 10.62. Entire left main stent looks circularly dilated. The repeat IVS was done only for the left main and proximal LED segment. Check angiography shows a very good result. Next one. With some amount of protrusion into the left main, that is expected. There was no distal edge dissection, no hemodynamic issues happened during the procedure. This is the final shot. We always take a RAO final shot in low mag to ensure that there is no pericardial effusion, distal perforations, the flow is good. Coming to the circumflex, you can appreciate circumflex ostium is only 50% disease. It's having TME3 flow, we didn't do anything. Unless patient has clinical ECG waves, hemodynamic waves, some issues, we will not usually open the circumflex stent at all. Thank you everyone for watching this. Appreciate it. Last but no means least, we had a strong cardiac anesthesia team. Today our anesthesiologist Dr. Kamal helped us along with his fellow. Thank you everyone.
Thank you. So to summarize, we had a patient, elderly male, who had a primary PCI to RCA, and the stent was highly undersized, underexpanded, stent deformed at the ostium because of guide possibly. Imaging definitely helped to confirm the problem. X-ray itself identified the problem. Imaging helped the problem to be identified. Following which we measure the size at the site where RCA ostium was not having stent. It is 4-O vessel. So we enlarge the 2.75 to a 4-O stent in the ostium. That is going to give a torrential flow into the coronaries. Already the stent was 2.75. The distal RCA was 3.1. We dilated the mid RCA stent, distal segment of the prior stent with a 3.5 NC balloon and a 3.0 OPN balloon. Following which we did rotablation to LAD 1.5 bar, and bed was prepared with a 3.5 NC, under-prepared, hence used a Wolverine 3.0, and then stented with the 3.5 Zoteromus eluting stent 34 millimeter, and pot was done with 4.5. Post-dilatation was done with that 3.5 for the LAD segment. We were not happy. We went ahead with OPN, dilated the entire LAD with the 3.0 OPN. Pressure is more important than size. You can appreciate the better lumen area gain after 3.0 OPN. And there was under expansion at the distal left main site near the carina and the ostium of the LAD. Hence, 4.5 was used up to 20 at the site of the carina, and just into the small protrusion into the ostial LAD went up to 12 there. We were able to achieve a decent size at the carina of 10.6. We went up to 20, took a 4.5. We don't want to take a 5.0 balloon to get a magic number of 12 in the left main. He's doing good. He went home. Thank you.
Thank you, Doctor. Excellent case. Before your case, the comment about the previous operator. When the RC was done, it was obviously on the imaging very underexpanded with deformed. So most of the time when people are doing cases with an acute coronary syndrome situation, the RC is in spasm. And at that time, use of imaging is very much useful to know exact size of the stent. So that I am telling about the previous operation.
No, I would say it is not it may not be the operator mistake. Most of us would have taken a 3.5 in the vessel unless we do imaging.
Yeah, imaging.
We are definitely would not have taken a 4. I don't think I would have taken a 4.0 stent for that RCA unless I see myself what exactly is the size there.
That's why in acute coronary syndrome, the vessel size may be underestimated, yes, and I was usually saying. Regarding your case, it's an excellent one. One point, basically 2 points. One is diagonal was very big size, I think. And at the end of the result, final sort, I think diagonal ostium was pinched. Did you think anything about that?
No, diagonal ostium was not pinched more than 70%. Otherwise, we would have definitely treated it. It was less than 70%. We don't treat even a circumflex pinched less than 70% without ECG changes, without chest pain, with a TME3 flow. Even a circumflex, I usually don't treat. They do good.
Second thing is, you use different stents with different drug eluting in two sites.
That's a great point. As far
what is your
as
take on that? I mean, how comfortable you are taking different type of stents? You use Megatron on this right RCA and used.
Yeah, that's a great point actually. There is no evidence to say that ISR that happens with ZES can be treated better with ZEES if there is a mechanical cause. It's a type 1 Waxman's issue. Considering why is Zoteromus on this side, Megatron on this side, and why Zoteromus again on that side, the size was not available. That is the only reason. We want if you put a 38, I was getting into the small segment of the intramyocardial portion of the LAD. 32, I may fall short. Hence, we took a 34, sir.
What was the dominant lesion in your dominant vessel?
RCA dominant, sir.
Any comments from audience?
The PDA also taken care?
Yeah, so I forgot to mention, we ballooned the PDA and DCB with a paclitaxel agent balloon 2.25. It was taken care. I didn't show, maybe it was there, I fast forwarded it, We ballooned the 2.0 balloon 2.25 and then it was good result. There was no flow dissection there.
What precautions will take with an OPN balloon? how do you select sites?
Yeah, OPN, we published our experience on OPN and CRM last year. The proposed suggestions include, if you are pre-dilating, if you are using OPN used for pre-dilatation, undersize it by at least by 0.5 millimeter. If you are post-dilating it, you can take 1:1. However, I would say go 0.25 millimeter lesser if there is going to be in a densely calcified portion or a tortuous one, number one. Number two, if you are taking OPN more than 3 millimeter for pre-dilatation or for post-dilatation, imaging is mandatory. Number three, if you are going to take OPN for its RBP, which is 36 ATMs, imaging is mandatory. These are all the principles what we follow. And we had two perforations in our series. Perforations are going to happen irrespective of any balloons. So one patient, it was our mistake, we were learning, it happened in 4.5 years before. We were doing a live case, we listened to the speaker, the chairpersons that they were suggesting us to take a 3.5. I was putting my foot down, no, 3.5 is big. However, I made a mistake of listening to them, not listening to my intuition. We took a 3.5, perforated, we salvaged on table, patient went home, he's doing fine now. The second patient, I don't know why it happened, but the second patient I did not image. So vessel was 3.5, I took a 3.5 angiographically, and it was a GE machine. Most of my perforation happened in GE machine. I don't know, maybe my eyes are tuned for Philips. This is my personal experience. So whenever I do a complex case, I insist that it should be in Philips machine. Maybe I got trained. My great visualization was better with Philips. Number two, and as I told earlier, I took a 3.5 OPN, but I do image. I burned myself and relearned myself. So never ever take a OPN balloon to RBP if you don't image. Never ever take a OPN balloon more than 3 if you don't image. Image. We are trying to expand it at the cost of someone's life. I will not do that again.
So when do you select a scoring balloon versus cutting balloon?
Yeah, I'm not biased toward Boston, but I don't like, personally I don't like scoring. I like Wolverine. That creates phenomenal results.
So, we know that the Wolverine has to be taken step by step when slowly. Do you employ any techniques to reorient the blades and cut in a different angle?
I use Dr. Samin Sharma's technique, what he taught me. I cut 2 times, number one. Number two, I inflate Wolverine every second 2 ATMs. My target is to expand it well. And if I take Wolverine, I underside at least by 0.25. If I underside at least by 0.25, I don't go more than 12 to 14. I intentionally undersize 0.5 millimeter. If I intentionally undersize 0.5 millimeter, I go to 20. I never go above the RBP if I size 1:1. Most often I don't size 1:1. I undersize. I want the pressure, not the size. It is the error on the size that create issues. And once you cut in one direction, take the balloon to the guide again, rotate it, and then go again and dilate again in the same side. This is taught by SS, so I am following the same.
There's one question. Great case. The only doubt was the RCA was actually a check angiogram, right? And you were surprised to see a crowding. So it was not lack of imaging in the previous case. It was actually the operator didn't identify the damage to the proximal. Supposing the RCA was okay, you would not have gone ahead with
yeah, of course.
So
it's
it was
good for the
basically
patient.
the lack of identification of the damage to the. So it was not the lack of imaging in the previous.
Yeah. Okay. Maybe it was in the. I asked we went to and it was 2 a.m. case. So most of us. Yeah, distal RCA, we did a regular balloon and opened the size and put a DCB. Maybe I can show that angio alone. Can you show it up? Yeah, distal angio, we just did DCB, sir. Yeah, this is the, you can appreciate the lesion is gone now. It will come, yeah.
Yeah,
this post
it's taken care. Yeah, we are overdue. I mean, we are over 10 minutes past the time.
Yeah, thanks.
The next session, we'll end this session and we'll call for the next session. Thank you. This session is over. We'll call for the next session. Challenging CD session presentation.
The topic for this session is Challenging CD Presentation, Complication and Nightmares. The facilitator for this session is Ajay S. Chaursia, and the chairpersons for this session are Pramod Kumar, Susint Khanna, K. H. Srinivas, Hen Kumar Agrawal, and Shalendra Trivedi. And the panelists for this session are Reddy Pagri Niranjan Reddy, S. Praveen Kumar Reddy, Rishikesh Chakraborty, Gaurav Bhattacharya, and Somejit Ghosh. And the discussants for this session are Dinkar Thati Matla, Kshitiz Prasad, Deepak Kumar, Amit Kumar, Jagdish Jayaraman, Nambirajan Jaibalan, Subhashis De, and Rajesh G.
We'll start the session. First, Dr. Puneet Patel, Complex Multivessel PCI in Dextrocardia.
Good morning, everyone. My case is complex multivessel PCI in dextrocardia. Case history: a 60-year-old gentleman came with chest pain on exertion, dyspnea on exertion, NYHA class 2 to 3 since 2 months, with non-diabetic, non-hypertensive, and chronic smoker. His vital on admission is normal. On examination, S1, S2 is normal, no murmur, bilateral minimal basal crepes are present. ECG shows sinus rhythm, QS complex present in V1 to V4, poor progression of R wave, and echo shows sinus inversus, dextrocardia, dilated chambers, and RWMA present at basal and mid posterior, basal and mid inferior, hypokinetic. Rest of the segments are severely hypokinetic. LVF is 38%. We have done angiogram with 5 French GL diagnostic catheter, and angiogram shows proximal to mid LAD 80 to 90%. It's a dextrocardia, so it is a mirror image of what we are doing regularly. So this is a LAO cranial, LAO 7 cranial 44 degree, and this is the LAD. This is diagonal D1, D2, and this is L. In this is the LAO caudal, so this is the LAD. And proximal LCX shows 80 to 90%, and this view is RAO caudal. Regularly this we are seen in LAO caudal. This is LCX and this is OM. This is L6, LAO caudal view. And RCA is a non-dominant and abnormal origin. We have tried with JL, JR, AL1, AR1, multipurpose and EBU diagnostic, but couldn't success to cannulate properly. Its origin here only and going back. So we have planned for PTCA. We have taken 6 French EBU guiding catheter and wired with BMW. We have done pre-dilatation with 212 mm balloon at 6 atmospheric pressure, and PTCA with DS2 proximal to mid LAD. We have done 2.5 into 36 mm at 8 atmospheric pressure. Post-dilatation done with 2.756 NC balloon at 12 atmospheric pressure, and we have achieved good TME3 flow, and it's going. Pre-dilatation with the 212 mm balloon, same with at 6 atmospheric pressure in LCX done, and DS to proximal LCX 2.5 into 28 mm at 10 atmospheric pressure. Post dilatation with 2.75 into 6 mm NC balloon at 12 atmospheric pressure, and we have achieved good TME3 flow. So the take home message in this is dextrocardia with situs inversus is a rare condition with an incidence of 0.01%. Though the incidence of coronary artery disease is the same as that of the general population, the angiographic image orientation is the main concern during PCI, as suitable angiographic projection can be tricky in dextrocardia. The standard image display in this unfamiliar anatomy may pose a technical challenge for selective cannulation of coronary ostia during PCI, and the importance of image reversal and catheter manipulation for selective cannulation of coronary ostia during PCI is the main challenge. Thank you.
Thank you, doctor. Excellently done. The important thing is imaging, doing in PCA. That's doing the opposite of all the images. What we are doing in caudal, cranial, whatever, is to mirror opposite. We should do.
Yes.
We should tell the technician also to do it in a proper way, so that we won't miss any lesion in the distal segment or in the new branch vessels. This case is excellently done.
Yes.
Thank you.
Thank you, sir.
Any discussion from the audience?
Actually, in some of the cath labs, there will be a button where you can totally reverse the system and do like a normal position heart. So that the views will be normal.
Coming to the next talk, unusual coronary perforation by Dr. Pavan Roy. Coming to the next session, Dr. Shankar Machigar from Nightmares in Cath Lab.
Yeah, good morning everybody. Thanks NIC for giving me this opportunity to present a topic of nightmares of these calcified lesions. So this was a 77-year-old male with known case of diabetes, presented with dyspnea on exertion and easy fatigability since last 1 month. Patient was stable. ECG showed T-wave inversion in anterior leads. So 2D echo was also normal. So hence we decided to do angiography. Radial approach was used. So initially it was very difficult to pass the Terimo wire after radial access to find only that there is a 360 radial loop. After that it was tackled with Terimo wire and we completed the angiography. It showed that LCX is dominant with 50% plaque in a proximal lesion, and in mid LAD we can see a long lesion which is calcified with 60 to 70% lesion. Since the patient was symptomatic, we decided to do FFR guided PCI. RCA was non-dominant. So while doing FFR, Again with the guiding, there was the same issue of radial loop, but we were not able to tackle it easily. Initially we tried with Terimo, then with coronary wire, then coronary wire supported with JR catheter. We were able to tackle that radial loop, but it was not able to pass beyond the elbow joint. So we decided to go femorally. So this was the second nightmare. Third, so switching to the femoral route, FFR was done, which was significant. Hence we decided to do and decided to do PCI. So the pre-dilatation was done of mid LAD, proximal to mid LAD with 3 into 12 NC balloon. Then like we do many times, that wire, coronary wire was used to measure the stent length, only to realize that there was wire induced dissection, which was minor. Then a long stent of Giants 3 into 40 mm was deployed from proximal to mid LAD, and the lesion was post dilated with 3.5 into 10 mm balloon. So after that, the check shoot revealed that the distal segment of the stent is still under expanded due to the heavy chunk of calcium. So we decided to use high pressure balloon, that is OPN NC. Since the stent size was 3.5, we used the post dilatation was done with 3.5. We used 30 into 10 OPN NC balloon. Initially we went at 30 atmosphere, but it was still not expanded. Then at 45 atmosphere. Suddenly during this procedure, patient suddenly developed chest pain, blood pressure had fallen, check shoot revealed that there is a perforation which is of grade 3. Then immediately with the same balloon tamponade was done at 10 atmosphere pressure. Patient was resuscitated with IV fluids and vasopressor. Then we continued the balloon tamponade. By that time we took the left femoral access and with the 5 French guiding catheter, we engaged the left main coronary and deflated that initial balloon and passed the wire, and we tried to pass the covered stent via the 5 French. Since the covered stent is bulky stent, we were not able to pass through it. So we have to repeat the same procedure, that is deflate the balloon, remove the covered stent, deflate the balloon, pass the non-NC balloon via the 5 French, give inflation, and via the 6 French, that is right femoral, we were able to put the covered stent with difficulty, that is 2.8 into 26 mm. The check shoot after that revealed that there was TMT flow with sealed perforation, but the fluoroscopy showed that there is still pericardial effusion was done. So pericardiogram was done. Around 100 ml of hemorrhagic fluid was auto-transfused. Then after that check shoot was done, which showed TME3 flow, no dissection and no recoil. Patient was hemodynamically stable and discharged after few days. So the summary of these challenges were, first, before angiogram we should always be aware, first was about the radial loop, then during the plasty there was coronary induced dissection, then under expansion of the distal end of the stent, during post dilatation there was perforation using OPN-NC balloon, and during rescue method there was difficulty in negotiating covered stent, and lastly the cardiac tamponade. So the take home message is, while doing angiography, always be aware that there may be a anatomical variants like radial loop and its difficulties in tackling. Try to avoid measuring the stent length with coronary wire to avoid dissection. High pressure OPN-NC balloon can be tricky, should always be used with image guiding. uninterrupted balloon occlusion at the perforation site is the earliest and the crucial method, and call for help. Modified ping pong method, that is double guiding catheter using a small size second guide, can be one of the rescue technique during this time. Covered stent delivery is challenging, and prompt pericardiocentesis.
This case actually managed very well, but two things is actually, if you do the imaging, maybe you know that calcium, degree of calcium and circumferential, whether it's a 360 degree or it's arc calcium. We can do some debulking before putting a stent, maybe IVL or maybe you tackle the calcium very well before putting a stent. And radial loop, maybe just putting a, sometimes you can go with balloon assisted technique. We can put a half balloon outside the thing. Maybe inflate with the low atmosphere, maybe we can inflate with the low atmosphere, maybe we can And the important thing is two things. One is imaging will give a better information about the calcium anatomy, and maybe a debulking or maybe you not had this kind of complications. A discussion from the audience.
The stent which was under expanded was 3.5 millimeter. It is also a reasonable strategy that whenever you are expanding with a OPN balloon at a high pressure and the stent is not opening, then downsize and then go at 50 atmosphere. It will break the calcium or fibrotic plaque, and then you use a normal 3.5 NC balloon, expand it, the chances of perforation would be very low.
Yes.
Thank you. Go on to the next case.
Yeah, thank you, sir.
Mistakes makes you. Dr. Sharath Shanmugam, sir.
This is a case of a 57-year-old female, diabetic for 10 years. She had a rest angina for 2 days. ECG showed sinus rhythm, ST depression in V3 to V6. Cardiac macros was positive and echo was normal. We treated as NSTEMI and proceeded for the angiogram. Patient had a type A lesion in the proximal LAD of 90%, followed by 70% after D1, where the LCX and RCA were and we dock PCA to the proximal LAD. We went into the French EBU and we engaged the catheter, where we had a type A dissection in the left main. With a compromised LCX. So we went into the femoral route with the JL 3.5 and engaged with the run-through wire in both the LAD and the LCX. Since the flow was good in the LCX and we had a TIMI 3.4 in the LCX, then we pre-dilated the lesion with the 2x15 NC balloon and we went to mid-LAD with 3x32 synergy and the ostial left main to proximal LAD with 3.5x32 synergy. Balloon and
We did a post-IVS imaging for the left main. There was stent under expansion and malopposition was noted in the ostial left main to LAD stent. So again, we potted the lesion with 4.5 into 8 NC balloon. The final IVS was done, which showed decreased malopposition, but we accepted the result and we came out. The final shot of LAD showed maximum the dissection was subsided. Patient was observed in the ICU, serial echo monitoring was done, hemodynamics was well. On 9 months follow-up, patient was comfortable, good effort tolerance. So the learning points is the care should be taken in choosing the right guiding catheter. To engage the guide catheter carefully, avoid too deep engagement. Low-grade coronary artery dissections in patients who are hemodynamically stable may be managed conservatively. Timely recognition and prompt bailout PCI is a feasible option for high-grade dissections, and the female patients are more and have worse outcomes. Thank you.
So well-managed patient. Two things. One is deep engagement of guide is one issue, and once you engage proximal LAD, just we can perfect contrast and we can pass the wire. It's a type A lesion only. It's not going to challenge anyway. And always better to choose a view which is you are using it regularly. Maybe LAO caudal spider view. That is easy for regularly. Maybe LAO caudal spider view. That is easy for us to negotiate. Easy for us to manage also. You're doing in some other technique in RAO cranial or something. You are passing a wire. Sometimes you will ask them staff to engage. Give some contrast or extra contrast. The guide is engaged deeply. Sometimes this can happen. And this is the ectatic LAD. So maybe the stent size would have 4 size. Maybe left main to LAD you have chosen a 4 vessels means that's pretty easy. And the second thing is last circumflex has some slow flow or something contrast says.
Yeah.
Some slow flow or something contrast says.
Yeah, slightly extend to the L6, but we had a distal
good flow just.
Yeah, we didn't intervene the L6.
Any other comment from the audience? Coming to the next topic, septal perforation and coil embolization and misadvent. Dr. Balakumar K.
Good morning, one and all. First, I'd like to thank Scientific Committee Organizing Secretary for giving wonderful opportunity to talk NIC 24. I'm Dr. K. Balakumar, DNB Cardiology Resident, Clinical Health City, Chennai. Recently, we had an interesting case and we managed. That case I'm going to discuss. So, case details. 48-year-old male, knee comorbidities, presented with chest pain for on and off 3 days. Initially consulted outside, they treated some gastritis like thing, given medications, ECG also not taken. So after day 4 came our hospital ER, on and off chest pain, not classical chest pain. So we took ECG that shows evaluated inferior wall MI. On the time echo was done, echo shows fair LV, 50 to 55%. Regional wall most abnormality in the inferior and basal region. Other blood routine was done that shows troponin T was elevated. Other blood routines within normal limits. Vitals and all stable. So then we planned for angiogram. The angiogram shows double vessel disease, proximal RCA 100% occlusion, and LAD at the level of major diagonal 90% lesion. then B for plan for PTCA. First PTCA culprit artery RCA was opened, TIMI stent was done, TIMI 3 flow was achieved, then plan for LAD. In LAD, the stent was done post PTCA. Check angiogram shows distal LAD perforation, moderate leak was noted. So initially we done balloon dilatation intermittently 10 minutes over 4 to 5 times. So that leak was not occluded. Then we planned for coil embolization. Let's see. This is proximal LAD 90% lesion at the level of major diagonal. This angiogram. This post PTCA LAD check angiogram showed moderate perforation of the distal septal vessel. Here. So meantime, patient screening echo done that shows no pericardial effusion, vital stable, hemodynamically everything okay. Patient also comfortable. So first we started balloon dilatation. That thing perforation was not sealed. Then coil embolization we planned. Cover stent was not chosen because of distal vessel and small size and very difficult to take an increased chance of thrombus and stent occlusion. So then septal vessel was selectively cannulated with pro-grade microcatheter. Then check angiogram was done. That shows perforation was sealed well, no any further leakage. Then we planned for Hilal microcoil embolization. Thing is here everything went well. So end of this stage proximal end is well occluded perforation area and distal coil is unfortunately came out and occluded in the distal part of LAD. So check angiogram was done that shows TIMI 3 flow is achieved, but chances of thrombus and occlusion is we suspected. So we did balloon dilatation and coil was well wall to wall, well apposition done. Then we planned for drug eluting stent 2.25. After drug eluting stenting was done, check angiogram shows flow is good, no any perforation, leakage or dissection. This is a final angiogram revealed, good flow in the distal LAD, no leak from septal perforation. I was also showed good opposition of the coil and stent to the vessel wall. This I was showing good lumen, there is no any other narrowing part. So take home message discussion is first appropriate size of the coil embolization of the distal and small vessel to be chosen, first thing. Second is hydrophilic whisper wire is not right choice in this lesion. And other simple methods like fat pad embolization and tip of coronary guide wire embolization, injection thromba injection, foam gel pad, that thing and all we can use. Cover stent also used, but in this lesion is distal part and small vessel. We should not give another chance to give thrombus or any other patient to the thing. So as there is a high chance of stent thrombosis in this patient, we started dual antiplatelet therapy, one single anticoagulant. Patients on regular follow it up. 10 days back also patient came. General condition is good, echo was little bit good. Almost near normal, previously fair LV and ECG blood report everything within normal limit. Complications can happen even simple interventions, hence be ready to handle effectively. Thank you, sir.
Two things about the patient.
Yes.
One thing, so taken a whisper wire lady.
Yes, sir. Because first we workers wire we use it, sir. The thrombus is a little bit hard, not able to cross the wire, sir. So that's why we go for hydrophilic wire. So same wire used left side, sir. That thing we should
Right
not
side, okay.
use.
Right side, right corner.
Yeah, right
used.
side, yes, sir. Right
And
side.
this is actually it's almost like a ADAC kind of situation where you had a double vessel disease. So this kind of situation, you tackle the RCA. You want to take without taking extra wire, just we use the whisper wire. That's the way it's gone actually.
Yes, sir.
So this kind of situation, better to take a workhorse wire.
Yes, sir.
Rather than taking whisper wire.
Yes,
And
sir.
always,
Yes.
if you're taking a whisper wire, make sure that you park the wire into the distal LED, not into the, maybe you kept the wire into the, while passing the wire, maybe the wire entered into the small septal
Yes.
branches.
Yes.
Second thing is, there is no hemodynamic compromise.
Yes, sir. No hemodynamic compromise in between or post-procedure.
Maybe simple occlusion for 5 to 10 minutes is more than enough. And there is no hemodynamic compromise, there is no pericardial effusion, patient is hemodynamically stable, there is no ECG changes, there is no further collection in the pericardial cavity. Then there is no need of any other further intervention is needed. Coil embolization is...
A coil
why you
embolization,
choose coil
patient
embolization?
own blood and injection, fibrin injection that...
No, that's okay. Why you this embolization, this coiling we done?
So that is on the time we available because patient hemodynamically stable. We tried balloon
See, if it's
dilatation.
hemodynamically unstable or there is a collection, progression of collection is there means maybe balloon occlusion, maybe coil is acceptable. There is no hemodynamic compromise, there is no pericardial effusion in this patient. So there is no point of doing a embolization. So this we can manage medically. So many small perforations. There is no hemodynamic compromise. Usually we won't do anything. Just we'll leave the patient and maybe we'll monitor the echo hourly. Once we'll see the echo, maybe we'll keep the radial sheet ready for the further intervention.
Yes, sir. We did 10 minutes over 4 to 5 times, sir. Around 45 minutes immediately in between we did, sir, balloon. In spite of thing, leak was not subside, sir. We had some past experience,
So
2-3 cases, sir.
The thing is
that
it won't subside because most of the things sometimes not entering into some cavity. So cavity you won't get any effusion.
Yes,
So draining into the cavity, you won't have any effusion. So many operators have seen this complication. So if it is draining into the cavity, there is no point of doing an occlusion also.
Yes.
But we'll do the general occlusion. And then there is no hemodynamic compromise, there is no collection. So mostly it will do the pericardial cavity, not into the pericardial cavity, into the draining into the LV cavity. Any other opinion or from the audience?
It was a wire tip perforation, there is no doubt, and it was not draining into the cavity. But still, it was a very small perforation and would have healed on its own. And if at all something, because coils and then stent, if at all you could have embolized fat or even blood clot could have been.
Actually, one case we experienced, sir. Patient same like a small perfusion. So we shifted ICU. It will settle down. Midnight around 2 to 3 call came. Patient having hemodynamically unstable. Then on the day, echo shows moderate to severe pericardial effusion, and on the time little bit problem patient is happened. So that's why we thought we should not give any chance to any issues. That thing.
That would happen, but we have seen one patient. We found that somebody else has done the angioplasty, and when I was taking the round, we found that patient had low BP and he did echocardiography. It showed moderate to severe pericardial effusion. Pericardial tapping was done. We took the patient to angiography and the perforation had sealed. So by that time, patient had tamponade, but it was a minor perforation and it had sealed itself. So we didn't require anything to be done except draining the pericardial fluid.
Thank you, sir. Thank you, sir. Sir, not audible, sir.
No, probably coiling would have been avoided. Whatever stain was there, it was because of previous extravasation, and it might have been sealed because of your balloon occlusion. Probably you could have waited for some more time inside the cath lab itself. And
45
if there is
minutes.
no pericardial effusion on echo,
Yes, sir.
and this is kind of asking for more trouble. So you could have waited for some more time. And since patient didn't have any symptoms, there was no pericardial collection, and you could have waited for some time, or you could have kept the patient in the waiting hall with the sort of radial or femoral catheter in situ. And in case there is any problem, you can attend. You can, carefully watch the patient. And if there is any problem, like the previous bad experience might have
Yes,
been
sir.
because of
Yes, sir.
some other reasons, but
Yes,
this
sir.
case, you
Exactly.
could have waited for some time instead of, putting a microcoil, coil embolization unnecessarily and inviting trouble. Probably that would have been a better option.
45 to 50 minutes we wait, sir. After this thing only, we coil embolization is planned. In between, we monitor everything, sir.
No, but patient didn't worsen. His condition
yes,
didn't
sir, yes, sir.
worsen
Yes, sir,
during
yes, sir,
those
yes, sir.
15 minutes.
Exactly.
No, there was no new development of pericardial effusion or anything. So you could have sort of shifted the patient and waited in the post, cath setup for some more time.
Thank you very much, sir.
Thank you. Coming to the next talk, coronary perforation by Rajiv Bhardwaj.
Thank you. Our patient was 1 years male, known case of type 2 diabetes mellitus with hypertension, presented with csiNIC in outside hospital, where CT scan was done and there was hemorrhage in the putamen region. So he was referred for this purpose, came to our hospital, he was in cardiogenic shock, and then call was sent to us just due to the cardiogenic shock, and we found that he had already been put on inotropes and BiPAP support, and we found that patient was having inferior LMI, complete heart block, heart rate was 32 per minute, and his BP was 50. Immediately temporary pacemaker was done, and patient was taken for coronary angiography, which showed near total occlusion of RCA in proximal part. Left system shows some plaquing the left main, but there was no significant stenosis. And right coronary artery angio was done, which showed near total occlusion with thrombus in mid segment. So since patient has very low BP, he had hemorrhage in the brain putamen region, we thought to in short time, we just passed the wire and did direct stenting. And you can see that during direct stenting, there is dog boning effect in the distal part of the stent. And when stent was removed, there was grade 3 dissection perforation. So immediately, same balloon was negotiated, balloon tamponade done in proximal part, waited for some time, but bleeding continued. We then took graft master. It could not be negotiated through the pinched part of the stent. Tried to cross the graft master with support of body wire. Still stent could not negotiate. Then tried guideliner support. There was no success. Then we thought we should dilate the pinched part of the stent so that we could negotiate the stent. So we dilated with the NC balloon, but still graft master could not cross. Neither stent nor graft, neither stent or nor with guideliner support. Then what we did, we pushed the balloon distal to the, in the distal part, inflated in distal part of the vessel, and then we could push the guideliner. And then once guideliner was across the lesion, it was not difficult. We pushed the stent, pulled back the guideliner, and graft master was deployed. Then was good flow. There was some spasm which was relieved after the antigen infusion. So patient remains stable. Echocardiography, minimal pericardial effusion anteriorly, did not require pericardial synthesis. He was still on inotropic support, but when patient was went to the cath lab, his BP was 50 on inotropic support. When he was outside, shifted, he has 110 millimeter mercury, and it was stopped on the next day, discharged after 4 to 5 days. So take home message, coronary perforation is an uncommon but dreaded complication of angioplasty. Female gender, older age, coronary calcification, CTOs, and use of rotablation are some of the risk factors. High pressure dilatation in presence of calcium and use of larger balloon or stent are also risk factors. You must keep your calm, call for help. Balloon tamponade and covered stents give gratifying results. Covered stents are bulky and sometimes difficult to negotiate, and you may have to resort to multiple innovations to be successful. Thank you.
Very well managed case, sir. Actually, here is direct stenting is always, even though in acute coronary situation or in the elective patient, maybe we thought maybe a direct stenting will give a solution.
We do many times direct stenting also in the acute coronary syndrome, but in this case, because patient was very unstable, intracranial hemorrhage, BP 50, we thought we finished the patient early and shifted back immediately because neurology, he was under neurology. So that's
usually calcium, the patient having a speculed calcium or arc calcium, this can happen once you expand the stent, because we are not sure. We want to expand the stent, maybe we'll go a little bit in a higher pressure, sometimes it can happen.
On a fluoroscopy, there is no obvious calcification, so we did direct stenting, but
yes,
ultimately
definitely without imaging is difficult. But the thrombus also is underlying, so we are not able to surely know what is underlying the coronaries.
Sure.
Any comment from the audience?
Good morning, everyone. Sir, I just want to ask, after putting cover stent, does pericardial drain stops immediately or does it take some time?
No,
does it occur?
It stops immediately.
It should stop immediately.
Yeah.
And after putting cover stent, do we have to heparinize again, because we have given the protamine most of the time to reverse it, and the cover stent have increased risk of stent thrombosis?
Most of the times we don't give protamine to reverse.
No one is using protamine.
You should never give protamine if you are able to handle the perforation. So because protamine will, you may create another problem by causing the stent thrombosis.
Like sometime we are waiting and observing patient for pericardial effusion, and taking, if the effusion develops, we are taking again in the cath. So that time, do we have to heparinize? If we are putting cover stent, do we have to give full dose of heparin after giving the?
Before putting a stent itself, we should give full heparinization.
You should, rather after giving graft, you should be more careful about thrombosis.
Okay, sir. Thank you, sir.
It is more thrombogenic than other stents, so you should be more careful in giving.
Thank you, sir.
So there is no any more question, we'll close the session. Thank you, sir.